So we are going to start that symposium. Please take a seat. So the symposium this year is dedicated to the elimination of hepatitis C, so at arm's reach. So I would like to thank GILEAD for organizing this symposium. There will be two parts. First, 4 short presentations from each of our teams, Perpignan, Strasbourg, Bayonne, and Marseille. For those of you who are in favor of parity or same representation by male and female, unfortunately, we will have male speakers. So we tried to have female speakers, but they did not come. So that was just to say that to begin with. So we're going to talk about the background, where we stand in 2021. We're going to discuss a program named Convergence, which was implemented by Gilead in 2017. Those were smaller groups in all different institutions, and so we had patients from all over France. Smaller groups, as I said, smaller groups that we would be following up upon. And this was an immersive program within our partner, again, institutions. So this is in the framework of a simplified patient pathway, which is in agreement with the recommendation by the High Health Authority. So those are patients with no comorbidity, with no anterior treatment of hepatitis C, no history of cirrhosis. And if these patients meet those criteria, they can benefit from a simplified treatment. Now, if we were to summarize, hepatitis C in a nutshell, so ALD6 for our patients, pangenotypic treatment in a single single dose, well tolerated. You have the site, which is here, which helps you with interactions, drug interaction. Since the 20th of May 2019, any GP in France can prescribe that drug. It can be administered in the pharmacy in the hospital or in an outpatient setting. It is useful for patients in a situation of social vulnerability or in case of comorbidities. And we have a number of randomized controlled trials in order to support this drug. So it is an interesting drug. It's an interesting pathway as well. Now, very quickly, those are the new information in 2021. There was a law which was passed on the 16th of June 2021 on the practice or administration of the drug in the TRODs, so in those first-line centers. So this is the case for hepatitis B, C, and HIV. So this was a recommendation of 2009, and eventually in 2021, we do have that screening test, which is available in those TRODs. So of course, now we need to train the first-line workers, and we need to be all aligned in order to be able to completely eliminate hepatitis C, potentially hepatitis B as well. Jean-Philippe is going to talk about the market authorization. So France benefited from a market authorization for early market authorization for some hepatitis C. When you diagnose a B hepatitis, it is always recommended to perform a diagnosis of delta hepatitis during the entire duration as well of follow-up of our patient, especially when there's also an increase in transaminase liver transaminase, while the viral load remains low. So anytime, in a nutshell, when you have a screening for hepatitis D, you should also screen for hepatitis C or hepatitis delta, because we do have a treatment whereby we can treat that disease. Last point, there was a decree on the 9th of September 2021 pertaining to mobile teams. And this is again aligned with all presentations that you're going to have during the symposium. So now this was really to provide you with some background information. And we are going to now make a few presentations which are related to Convergence, Convergence being the GILEAD program. Now again, to pick up on this decree of September 2021, there's not a single line on funding, but from the High Health Authority, I know that there will be call for tenders next year. So there will be call for tenders, and you'll see whether you can apply for subsidies for your mobile teams. Now, the Convergence program with 4 cities participating to that program. So our friends from Charleville-Mézières are not represented today, but they took part to the Convergence program. So Jean-Pierre in Bayonne, Jean Remy in Perpignan, and ourselves from Strasbourg. In a couple of slides, we are going to present what we did in the framework of Convergence. What we had was an association in between our 4 cities, again, to leverage the benefits of learnings from all centers. So I started the symposium by saying that there will be 2 parts to this symposium. First, 4 short presentations, and then a roundtable open to a discussion with the public. Now, the first speaker is going to be Jean-Pierre, everybody know him, and Joachim LEVY, who's a representative from an association named Nouvelle Aube. So we have a good representation of the entire French territory. So teams representative from the north and the south, and also the eastern and western parts of France. So in a few words, I'm just going to present what we did in our organization in the Expert Center Against Viral Hepatitis in Alsace. The name is SELHVA. Our organization could be summarized in one slide, that one. So we are an expert center, and we are in charge of a number of missions that were imparted on us by the ministry. So training, research, and also help in the patient's pathway. We have a cross-cutting expertise with GPs, but also specialized medical doctors and nurses. And of course, we also create a link with outpatient settings, with GPs as well. And we have a mobile unit driving to the populations. So this mobile unit we've had since 2019. We have pathways dedicated to the different types of patients, again, in an outpatient setting, in an inpatient setting, for those patients also that we reach out to. And we have conventions in between the association, the different structures, and also the NGOs, Médecins du Monde, to name just one of them. We also have a research program in collaboration with the university. So our mobile unit is compliant with the decree that we just talked about. So it's a multidisciplinary mobile unit. So this is really a mobile unit in order to be outside the walls, in order to reach out to those population who do not present for screening, people in a situation of precarity, people in prison as well, or migrants. So we try not to overlap with the population that are served by carrots being another type of structures for people in situation of social vulnerability. So the idea really is to reach out to those people and have a better meshing on the territory. So a number of missions. Obviously, we have we have ordered a vehicle. The vehicle here is not the one that we use, but it always takes time to receive those types of well-equipped vehicles. Now, you have the different stakeholders in Alsace. So this is the Convergence program. So those two programs we hosted in the framework of this program, we hosted 20 people, and we were able to develop a number of relay solutions. Very quickly, our research program named Fibrous Scan, it was concluded last year. It ran between 2012 and 2020. We had close to 4,000 patients included. We had 19 devices and centers taking part to that. And we really want to compare imagery in between the reference situation and the end of treatment with interferon or other treatments. So this FibroScan program was concluded in 2020, but we launched a new program starting in 2021 with a high support from the High Health Authority, which was very fortunate. We received that support recently for the 3 to 4 next year. So we're very happy about this. And we will be able to cover all liver diseases with high sophisticated devices. We also have a degree that we train students in collaboration with the University of Nancy. Now, I give the floor to the next speaker.
Je ne voudrais pas que ça m'attire des ennuis. Hein, je n'ai pas déménagé.
I haven't moved. Those are my conflicts of interest. The mobile team at the hospital of Perpignan has been around since 2013. Our target is the vulnerable population of drug users, psychiatric patients, prisoners, migrants, and homeless people. Our partners are not very original compared to what Frédéric just said. So we focus on all hospital departments. We have a program which is called Zero Hepatitis. So we improved the situation within our hospitals, all associations outside of the hospital. We have two XAPA, one association, and one in a psychiatric hospital, and community associations, and those working with poor people, with food banks, housing, our partners for many years. These are all the services we offer. In blue, the basic services. In green is our mobile home. When we go to white areas, whether geographical or social white areas, when they have a facility, they don't have water, and so TROD, Fibrous Scan, etc. Specific programs. We have Zero Hepatitis Prison, Zero Hepatitis Hospital. We have programs around metabolic diseases with a sports instructor, and in yellow, that's what we're thinking about. On the bottom right in purple, the actions in the psychiatric hospital and the day centers to screen for viral hepatitis, and the program on recontamination. Our tools, since 2013, we have accumulated equipment. Everything is still working. We have 2 cars, a small truck, and a mobile home. We can measure the viral load in 15 minutes. The treatment, we've treated 7,000 people, 7,500 TRODs, and 19% patient with a positive serology. We started 817 treatments, and we have and 799 patients were cured. And reinfection is not frequent, but it's always for the same profile of patients. That's why we are working with a sociologist on this issue. So I have my pretty slide that's showing our tools, our partners, and all our services. It's all really every action with a new partner is based on the diagnosis of the needs. We don't come with a ready-made pack. We adapt. We try to adapt to the situation. And often we spend a few days in the structure to see how people are working and what we can provide to them. Thank you.
Bonjour.
So, hello again. Just to specify, well, I really encourage you to participate in these scientific sessions, but I would like to say here that, well, we were told to speak about the experience here of BZA in Bayonne, and I thought that this experience was quite unique and exemplary. So let's get started. Yeah, so very quickly, because this is important. BCA comes from Zappa, which was founded by in '74 by Médecins du Monde, related to methadone treatment, and therefore, this care center was right after the methadone center. And then, after the opening of this care center, patients got into treatment, but there was also the appearance of HIV, and then in '96, with rapid and therapies, the comorbidities were quite fast, and then there was hepatitis, and patients died of it. And another remarkable event regarding this was a trip that we made to Vietnam, and there I had the occasion to meet Thierry Boilard during that trip. And at that time, he was a professor at Saint-Étienne, and he said, do not always listen to hepatologues, because first of all, at that time, we used to refuse those who were using alcohol. So, well, they were having hepatitis, but they were also using alcohol, and that, of course, was contraindicated. So they were refused. So then we had to fight and fight and fight in order to treat. So that's why we got interferon, and that's why we started. And then we established a collaboration with the hepatology ward at the hospital of Bayonne. And actually, well, this was a service that was quite a pioneering service. And I think that lots of developments come from that time. And it's true that patients coming from that ward, and they didn't always go to care centers then. And then we installed Oxapa, which is another care center, and in the Basque coast. And here we could make new experiences. And we thought that if we were using the usual pathways, the safest thing was to find a way to work with associations. So this is what we did. We collaborated with Resapsad, with different networks, and we had this Resapsab available to all the pathologists, and this was very important in order to access treatment, in order to remove that stigma from drug users of having hepatitis C. And I wouldn't like to go into more detail, but I'd like to tell you that there's this new binomial team of EXAPA nurses and a pathologist. So this nurse will prepare the monthly consultation that the pathologist will have with the patient. So she will screen, she will oversee the treatment, she will use tools against infection, she will analyze if there is any further contamination. So that was it for 5 minutes. And this binomium, this team, this dual team is crucial in order to provide the right treatment. And actually, the summary of it all is that we have treated over 984 patients since 2011. And in the last years, well, we had 9 patients treated in 2020, 11 in 2019, and there were more in the previous years. And now we do not have so many patients anymore. So our only problem is that, well, we need to keep mobilized to seek for these patients. So we need to find the positive patients, and this is the harm reduction team. And we have to just screen upstream. And well, I would like to thank you for your attention. I have many other things to say, but maybe during the discussion. Thank you very much.
Bonjour.
Hello.
Levy,
My name is Joachim Levy. I'm the president of the association Nouvelle Aube. We work in Marseille. We also are a group of users, and we support drug users. So I'm going to discuss my association, and I'm also going to discuss the interest of this convergence program, which helped us find partners and helped us to have new inspiration as well for our actions and our future actions as well. So we cover a number of population with chronic diseases in situation of high precarity, and we work as well with many young adults with all difficulties that we have, young people without resources, and a lot of social difficulties. So we work in the streets. This is really our specialty. We have about 25 meeting points in Marseille. And we try to locate as quickly as possible the high precarity patients. We work with CARUD and the other associations as well. We help with the patient pathway, and we also try to scout the different areas where we may find those people and reach out to them. We were able to be trained as well in order to even further the quality of our care. We have different categories of points, entry points that we have, and I'm not going to go into details, but I will show very quickly how we support them with chronic diseases. Marseille is a very large playing field, so to speak. We share that playing field with a number of other partners as well. You see the sites where we work in the streets, in the different areas where we intervene. We also helped with housing. We helped a number of users to have access to housing. We were able as well, with the help of the Town Hall of Marseille, to place women and children in situation of high social precarity to be hosted in a former youth hostel. We have partnerships in the entire department as well. And we have programs, especially for screening, where we reach out to those populations in other parts of the sub-region as well. Or people are trained to perform DRODs, to perform a number of screening tests, and in the team we also have nurses. COVID was difficult; it hit us hard, as all of you, and so as soon as it was possible, thanks to our partners and thanks to GILEAD, we were able very quickly to restart the screening tests, and GILEAD also helped us with our mobile units. We were inspired very much by the projects that Jean REMY presented, the project that they had in Perpignan. We visited them in Perpignan in the framework of the Convergence program, and we are very much impressed by their project. We learned from them on how you can have that mobile unit and how we can reach out, how we can propose care to those patients. This is a program with collaboration of the European hospitals. I thank Marc Courier from the Saint Joseph Hospital in Marseille, and I thank also all the partners here who help us have a comprehensive project all along the patient pathway, from the screening test to the entire management. For a quick reminder, my presentation is as short as possible. Thanks to the Fibrous Scan device, we were able to reach out to 75 patients. We were able to implement a complete patient pathway for 8 patients. So complete pathway or for hepatitis C, from the screening in the street to the management directly where those people live. I would like to seize this opportunity to present you a magazine that we publish named Sang d'encre. And this is a free magazine, which I recommend to you. I recommend that you read it. It's very interesting. We have testimonials from users, but also from healthcare and social workers. Right. So we're going to keep that beautiful slide as a backdrop. Thank you very much to all the speakers. Thank you very much for sticking to the time allocated to them. I know it was not easy to have a short presentation, but it was very important to keep some time for an interactive session with questions. So who would like to jump in and ask the first question? Mr. Asala? Thank you for asking the first question. It's always the most difficult question. Okay, thank you very much for this sharing of experience. I wanted to know what was the impact of COVID on your activities and how you were able to jumpstart and restart your activities. So what would be the lessons that you learned in that context? Well, it is true that COVID stopped a number of our activities and missions, especially our Fibrous Scan program. We were not able to conduct that program anymore. And so what we try to do is try and protect our users. So as Joachim said, we were not able to perform TRODs. So it was difficult for associations. We didn't have the authorization to do so. But now that the situation is sort of under control with the pandemic, everything has restarted again. We have a number of people reaching out to us and wanted to be screened. Well, I don't know what the situation is in your center. Well, as a quick reminder, we remained open in our XAPAs and our CARODs, so in the different institutions, people were in lockdown, and people in the street were locked down in the street. They did not have access to toilets. They did not have access to the places that they usually go to. It was difficult for them to do to have access to hygiene situations and or institutions. So in some instances, we were able to continue tested. We were also able to continue with some screening with some of our volunteers during the first wave, the first lockdown in the Basque Country. We had very little incidence rate. So we were in lockdown, but the incidence rate was very slow. So a number of people were afraid. A number of healthcare professionals were closed. Or what they did was a video conference or remote consultation. And of course, how can you test in a remote setting? By the way, now that this situation is sort of normalized, our entire team is now vaccinated, and all of our staff came to work during the entire lockdown period. And one of our GPs had COVID in the entire period of time, although she was vaccinated, but she had a mild form of COVID. But then, fortunately, none of our staff was contaminated. So we tried to maintain some level of presence on the territory, which was not necessarily the case in other regions. As far as we're concerned in Marseille, we knew that Marseille, we have many layers of precarity, and the COVID crisis really shed some light on other level of precarities that we were not so much aware of. So of course, because of lockdown, there was a lot of wards and services that were no longer available, especially for mental health. It really, as a consequence, we had more work in the street, and we also had to reach out and raise awareness in the wider public. We conducted many reflections and brainstorming sessions within our team. We were also very much worried, obviously, that people did not access sterile material, and we were afraid that we would have more contaminations with hepatitis B or hepatitis C or HIV. So as soon as it was possible, we resumed our Fibrous Scan program. In Perpignan, the first wave was quite mild. However, we were in lockdown as of the 17th of March. We had a hotline, phone hotline implemented. Now, many of our partner structures resumed their activity months later. Some only opened in September, and then they were in lockdown in October again. So basically in 2020, the problems that we were faced with were mostly because our partners were closed. As far as we were concerned, we had a number of issues with our partnerships with the hospitals. We had also a hard time with some of our partners, and also in many hospitals, mobile teams and consultation outpatient settings. Some of our staff was dedicated to COVID testing, and so you know, this is how the crisis was managed. Could you please circulate a microphone to the person who'd like to ask a question? Hello, thank you. I work at the Ministry of Health in the Ivory Coast, and I'm very interested by your experience and the experiment that was conducted in Perpignan with Jean-Michel. I'm in charge of a national program in my country pertaining to HIV and hepatitis B and C. Now, with drug users, it is, of course, very interesting that the drug users can be reached out to directly in the street, directly where they live. However, we have some diseases with viral hepatitis. So we have a good program with HIV, but what you explain is that a GP member of your teams are able to also manage viral hepatitis. Now, when it comes to outreach, and thank you very much, Jean-Pascal, for inviting me to that seminar, by the way. But so my question, I was I'm concerned when it comes to the testing phase, and I'd like to tell. I'd like you to tell us more about hepatitis C. So, hepatitis C is a disease where you can have what we call a concentrated disease management. So, we have a test session on a half day when we have a patient with a positive serology and if they are covered by the state health security, a basic state security, in a matter of 5 days, we can measure the viral load, we can perform Fibrous Scan, we can perform counseling and implement treatment. So we can draft a prescription and the patient can go out to the pharmacy and get treatment. So it's in the framework of Article 51, which again is a sort of lump sum, which is dedicated. It's a sort of innovative process. For you interested, we have a study on this and we'll have the results on this Article 51 implementation later this year. But in a nutshell, there's a lump sum dedicated to screening, counseling, and treatment. Beatrice from Marseille. In Marseille, we have a study with INSERM, PHS, Médecins du Monde. And so this study was conducted in order to qualitatively and quantitatively measure the results of our action. So this is not so much a question, but rather a remark. We see that there are a number of initiatives out there starting from harm reduction programs. Sometimes we have a relay in the hospital. So we have a wealth of initiatives. Jean-Pierre really wants us to help people in high social precarity, but we are reaching out more and more to people with no social security whatsoever. And I think that we should raise awareness in the ministries. We need to find a solution for those people that have hepatitis C, but they have no access to healthcare. And there are also ethical considerations here. So because it's not ethical to test those people, tell them that they have a potential lethal disease, but we cannot treat them because they are in a situation where they do not have access to healthcare. So I would like that conferences like this one is also a platform to have more inclusive access to healthcare. So maybe what we didn't show in our presentation is that in all the experiments that we conducted, in all of our teams, we always dedicate time to social counseling. In our teams, we have social workers. Now, when it comes to access to healthcare, there may be a reform of the universal access to healthcare. A number of candidates to the future presidential election are against this, so maybe this would change. But except for particular cases, especially when we have people from outside of the European Union, sometimes it's easier when you have someone from Ukraine, it's easier to treat them than someone from Lithuania, for example. So treatments are paid for, even if you do not have access to CMU or ALD, which are two programs for universal access to health in France. Now, again, the experiments are different in the different regions of France, but generally speaking, there's a decent access to healthcare. I'm sorry, the lady is interacting, but without microphone. But I agree, but this is very different depending on the territory in which you operate. I had the occasion to talk with colleagues in other parts of the country. And I'm going to take another example. For example, the way antiviral drugs are reimbursed or not reimbursed or paid for, covered by in the entire territory in the same way. And this is not the case. Antiviral drugs in a psychiatric ward should be paid for by the health insurance, the state health insurance. But for example, in Occitanie region, some have a budget and dedicate a budget for antiretroviral drugs for patients in a psychiatric ward. So there are a number of things that need to be homogenized. And those details, of course, have a high weight, but it is true that treatment of those patients in psychiatric ward, we've been working on this for maybe 6 years, and we also have those people in situation of high precarity, and we must find a way with representatives from different associations so that everybody today can access treatment for hepatitis C. Well, thank you very much for your presentations. I come from Belgium. I have 2 questions for my colleagues in Marseille. We're very interested by the experiments that you conducted, how did you involve peers in that program? And my second question is to all of you, how do you use Cephagen experts? Is it paid for by the state health insurance? Do you do test and treat, i.e. no further blood work after that? How do you announce, how do you break out the news? How do you break out the diagnosis as well to the users? So to be very clear, we are a group of self-support and self-help, and which means that the work with peers is present at the different levels of our action. And we all peers and peers workers, including nurses and including the social workers. So this is something that we were able to demonstrate in the last 10 years, the fact that we can say that you can be reliable and also a peer. This was not easy. We had to demonstrate that. We had to demonstrate that to the High Health Authority. And the High Health Authority in the PACA region, so around Marseille, was convinced by our proof of concept, so to speak. So we do have peers present at the different stages, from the screening to the implementation of care. And they help as a go-between, so to speak. And so, yes, they are involved at all stages. Now, in our experiment, what we do is test and treat, as a matter of fact. So sometimes we have a remote consultation and the dosage of the viral load by gen experts. So of course we certified the procedure. We are compliant with the ISO procedure. So it took us a long time to be certified, but we are certified. So all results are validated afterwards by a lab, and the lab validates a test, either whether it is positive or negative, while the text is provided a viral load as a figure, but it doesn't change anything. This test is not paid for. In my project, this is an Article 51 project, i.e. it's financed by the state. We have a subsidy. And if this experiment is successful, and I hope it will be, then there will be a lump sum dedicated to those people with a positive result to the screening. So there will be a lump sum dedicated, whether the test is positive or negative, by the way. And we hope that this lump sum is as high as possible, because that lump sum should cover the Fibrous Scan, the nurse consultation, GP consultation, social consultation, and SELHVA as well. So we hope this lump sum to be as high as possible, because those projects under Article 51 aim at implementing a lump sum by patient. So results in January and hopefully will be successful. And if we're successful, we'll have a lump sum for this intervention. Now, for a structure like ourselves to purchase such a device, this device costs 22,000 euros, and then you have a maintenance contract of more than 2,000 euros per year, and then each test device itself is expensive as well. So you need a budget, right? You need a budget. And there is this experiment, this study conducted on Cepheid. And, there's a wide range of prices. In the past, we could purchase a GenExpert very easily, but this is no longer the case now. It's difficult to access GenExperts if you do not have a protocol validated by the state. So this equipment, on the other hand, is also quite sensitive, needs to be maintained, and you need to have someone maintaining the device. So it's pretty complex. There's a question there. May I start? My name is Hélène. I am a GP in a XAPA in Île-de-France, so around Paris. We have real issues in purchasing Fibrous Scan. And we also have issues in getting a number of people having access to care. So we have a number of patients with right to access to care, but we have a hard time sometimes getting their treatments paid for. So in the recommendation of ATHS with Fibrous Scan, you have an immediate result, but if you only have ACTI-test, you can use it as well, and both should be paid for. So either ACTI-test or Fibrous Scan, and it is paid for at least once a year, I think, for initial diagnosis in the follow-up. Of course, it has to be for an hepatitis C, untreated hepatitis C. Yes. Two questions. Yes, you have a floor. You have a floor. Daniel Bader, the president of a network of first-line centers. I think it's very important that you continue and involve GPs and private practices. So there should be every time it is possible, you should have a collaboration between XAPAs and CARODs and private practices as well. Because obviously, Frédéric could confirm, when you have a Fibrous Scan in a private practice and then you train GPs, then you have extraordinary good results. We have a number of patients treated in private practices, but again, we need to have the right hinge, the right articulation, so to speak, in between those different structures. And I think it's very important. I agree. We had tests in Alsace, but unfortunately, we do not have enough GPs taking the time to be trained and to do that systematically. Now, the problem, as in many regions, we are short of staff. We are short of GPs. There are too few GPs. The older GPs are coming in retirement age, and when they retire, new GPs, they take up their patient base and they do not extend the patient base. And maybe it would be good that in first line medical center, when you have multidisciplinary medical centers, it would be good as well to have such a fibrous scan. And FIB4 is a marker that can be measured in blood work, but we have a number of false negatives. And so we do need a fibroscan at some stage. And so it would be good to have a fibroscan performed either by a GP or by a nurse. And it'd be good to have that in those multidisciplinary health centers that we have in some territories. And this will be easier when the CNAM and the High Health Security do allocate a lump sum to the treatment of hepatitis C. The High Health authorities said that they would give their opinion by the end of October, so end of this month, for a number of viral diseases, viral liver diseases. And if they are in favor of that, it will be easier to have a fibrous scan in a number of those centers. And that would be very favorable. And this will help also with the return on investment, so to speak, and amortization of that fibrous scan. Now, we also had an experiment in our microstructure. A fibroscan was placed at the disposal of a GP for 1 month, and in a matter of 1 month, we were able to perform 200 fibroscans. Now, of course, we need to raise awareness with GP, but when it works, it's extremely powerful and extremely useful. Yes, to pick up on what was said, of course, you become proficient and good at doing something when you do that on a regular basis. And indeed, if you do 200 of those fibroscans per month, that's the minimum number to be proficient. For the protocol to be validated, you need to do at least 70 per month. So it's important to have that quality insurance, so to speak. And I think it's a minimum. Any nurse performing fibroscans should perform at least 70 per month. So I think it's per month because they said per month and per year, it's the same sentence. So I'm not sure. But anyways, so this, of course, is part of a more comprehensive way to manage those populations. And beyond hepatitis C, we need to talk about all liver diseases. And I think that type 4, therefore, is a good tool which helps in sorting or to have a first triage, so to speak, of our populations, because we do not have enough fibroscans. And of course, we need more training because it's all very nice and well to perform fibroscan, but then you need to be trained in interpreting properly. There's little time left. We have a couple of questions. Please, short questions, and we will provide short answers. Thank you for this debate. Thank you for your actions. Each of you are important players in your regions. You have long-term projects. You're here to support vulnerable people. But for those of us here trying to be inspired by your actions, what would be the key to success? What would be the advice that you gave to someone who would like to improve the management of vulnerable people? So I would like to have the advice of each of you, maybe in one sentence. First would be an appraisal of the needs. For me, I would say, so first, appraisal of the needs by the different structures. My advice would be, well, do not become discouraged because when there's a will, there's a way. My advice would be collaboration. Everything exists somewhere and you need synergies. And for that, you need collaboration in between the different associations. And you should be very generous. You shouldn't try to get all merit, you should be able to collaborate with the hospital, with private practices as well. Daniel was talking about microstructures, where with the help in the Basque country, there's a microstructure in the eastern part of the territory. We also have a mobile structure thanks to this collaboration. So we have a mobile fibrous scan in the microstructure, but also in Saint-Palais, which is in the center of the Basque country. So all this to say, and also address the question that was asked previously by Beatrice, as far as we're concerned, we have problems with migrants. We have a number of migrants from sub-Saharan countries in Bayonne. But to date, we've had very few refusals in terms of reimbursement. So our health authority was able to finance a number of this treatment also for migrants. And I would like to thank the ARS, the High Health Authority here in the region, because they finance a number of things, sustainable programs, and they are very generous in the subsidies that or funding that they provide. And so I would like to thank them for that. I would say a good mapping, a lot of reach out programs, and trying to work with partners. Now, Etienne Camerer, I used to be an addictologist towards the end of my career before I retired. I was a coordinator in a microstructure as well. And we were one of the first structures with a fibrous scan in my practice. Now, the question of fibrous scan being time-consuming in the practice, well, it depends. I was dedicated half days or full days to fibrous scans, and I could do as many as 30 per half day or day. When you have a fibrous scan and you share it with other practices and you're properly trained, and then you have GPs or addictologists, and if they have an active patient base in need of that, it's possible to do that. Well, this is what we do in Alsace. We have a fibrous scan that we share in between a number of practices. So hello, everybody. Sarah Yacoub. I think there's a point which I think is very essential in all the tips that you provide. Of course, you need to motivate people to become tested. A number of people in the general population are not aware of the possibility to be tested, be it in prisons, be it in the street. They are not even aware that it exists. So we dedicate reach out session to raise awareness so that people come and be tested. Well, indeed, it is true that the High Health Authority is not in favor of a general screening of the general population because it is not cost efficient. And it has been shown in the past that a general screening is not cost efficient. So you should probably concentrate on at-risk population. This, of course, is making our life more complex. And maybe age could be a good criteria. Maybe we would have a more cost-efficient procedure if we concentrate on by age groups. Now, of course, when you reach out to those very vulnerable populations, of course, they are happy that they were tested. And word of mouth is very important as well. So word of mouth is key in those populations as well. So if you work well, if a user is happy that they were tested, they will talk about it and they will address and refer friends, so to speak, from the same background. And also, we should leverage peers. And I do invite you to read the poster of Hélène Delagny-Rigaud on that, on a program that she's conducted in her region. A last question, potentially. And if there are no further questions, I would like to thank GILEAD for organizing this symposium. Thank you very much for staying here, even if you didn't have lunch. So you had to skip lunch so far. So thank you very much to all the participants, and thank you to the speakers as well.